30 minutes.
Okay. Mhm.
All right. Welcome back to Oasis Women's Functional Medicine. Today we are going to be talking about PCOS, which is one of the most common endocrine abnormalities that I see in my clinic with women. And I have a special guest here with me, Dr. Dintiman, who is a board certified dermatologist. And so I'm so excited to have you here. Can you please go ahead and introduce yourself to the guests?
Great. So glad to be here. Yes, I'm Dr. Brenda Dintiman, and my practice is called Derm Utopia. And the concept is to help you love the skin you're in and for us to be available to you many ways through our app, through virtual visits, and in person here in Vienna, Virginia. So I'm really glad to be here to talk about this very important topic because we see it every day and it really affects people's lives day in and day out.
Yeah, so, if you've ever had to deal with stubborn acne, excess hair growth, or changes in your skin that's just very untoward, you can imagine as a woman, it becomes a lot when you try different skin products and you try all these things hoping to get some relief, and then you find out that you have PCOS. So, can you tell us a little bit about how it shows up to you in the office with women?
Yes, it can show up different ways. I think the most common way is someone develops acne, and it's many times it's on the chin and jawline, and can be even a different acne than they had as a teenager. Maybe more undergrounders, as we call it, little cystic, not so much whiteheads or blackheads like we used to call them on the nose when you first get your teenage acne. And we also can see occasionally excess hair on the chin or
Okay,
that they don't normally get hair. So that's one of the main reasons that someone will come in to ask for my help.
I see. So, yeah, so even with me, I get a lot of consults, and women come and they say, I have PCOS, and I was told to start this like birth control. Um, what are your what has been your clinical experience with using birth control and skin issues as it relates to PCOS?
Well, typically, if someone is on birth control or would like to use birth control, we try to steer them away from androgen-based birth controls. So something many times that is like a low estrogen. Occasionally, people will do well with some of the ones like Yaz and that are specifically for acne, but I prefer a more balanced estrogen progesterone combo. But many times they'll also need an oral medication like spironolactone. It's become
Gotcha.
the main drug we use for acne. When I first started in
I
practice,
see.
we used so many antibiotics, and we can go there with functional medicine, the problems that caused, but we were always
Just,
using
yeah,
antibiotics and then Accutane or isotretinoin. But now we know that spironolactone is often getting to the cause of the need to calm down the androgen receptors that are not only triggering excess hair, they can trigger hair loss and breakout.
yeah.
So, multiple things that can come out of that one benefit of using that medication.
Gotcha, gotcha. And I forgot one important aspect of our session. I wanted to start with some myth busters for
Okay.
PCOS. And I want to just go back there because I want to get people excited and just to learn some quick facts about PCOS before we go into more detail about what it is. So, myth or fact, PCOS always causes acne. Is that a myth or a fact? Ooh, okay. How about dark underarms are a sign of PCOS? Myth or fact? Okay.
Mhm.
Hair loss and hair growth happen together in PCOS. I think Fact. Okay. Diet alone can clear PCOS related acne. No, wow. Okay. And skincare products can treat PCOS skin issues alone. So skincare products. No, wow. So we should forget about the $200 skin regimen. Okay. I love it. PCOS skin changes are purely hormonal. Oh, okay. PCOS skin issues appear suddenly after stopping the pill.
They can.
Yeah, they can. Okay. You will have to see both a dermatologist and an endocrinologist for PCOS skin.
If you can, yeah,
Yes.
definitely.
Okay. But it's so hard to get into those appointments. And so sometimes we have to do like a holistic approach. But next, number 9, PCOS acne is only on the jawline. Fact or myth? Oh, okay. Acne always improves after menopause in PCOS. Oh, myth. Yeah, and I've seen, yeah, and it's so true. I've seen, people develop acne when they go into perimenopause, and in menopause, it's really um the last thing one person needs while dealing with perimenopause and menopause is acne. I know some women who did not have acne as teenagers and then they develop it in menopause. It's really weird. But thank you for busting some of those myths for us.
Yes.
So yeah, so as functional medicine, I get a lot of these calls, PCOS, and now the diagnostic criteria is different. So basically, if you have like a hyperandrogen state, meaning like your blood work is showing high um, androgen levels, whether it's testosterone or DHEA, or high insulin levels, and then also cysts on your ovaries. These are 3 criteria. You just need 2 of them to actually qualify to have PCOS. Whereas at first you needed to have cysts on your ovaries. So we may end up changing the name of PCOS if that's the fact, right?
Mm-hmm.
Um, and it's mostly driven by insulin insensitivity. So how does that look like in clinic, in the dermatology clinic?
Well, I think one thing we've learned many, many years, I would say, don't worry about what you eat. Eat pizza. People thought the oil on pizza caused acne. And later we found out, it's been a long time now. There was a wonderful dermatologist, Dr. Bill Danby, who was the
Okay.
first to realize that milk and dairy triggered acne. And I think
Okay.
then that became more evolved into, we knew it was probably high glycemic foods, so the
Mm,
concept of high glycemic foods and how it triggers acne became very important. And one time I was just teasing and said, the young people I notice have become sort of the Frappuccino crowd. And I don't think that's the way we ate breakfast in the morning, with a big Frappuccino of dairy and sugar. And I was seeing
correct.
more acne and more
Mm,
sort of signs of, maybe I didn't label them PCOS. I don't like to label them first, but just different way of going through teenage years, and their acne seemed different to me. This was about probably
oh,
years ago. Yeah.
oh. So remind me, the teenage acne versus PCOS acne. Can you give us like some telltale differences or just like regular
Well,
hormonal acne? Like how do they look in clinic?
I mean, they can be very similar. I think it's not
Okay.
that there's a totally different type of acne, but you may see someone who says, I've had clear skin and now I'm getting more cysts around the mouth or jawline. And we might see that coming out even like in somebody's late 20s or 30s. I never had acne. Whereas the more classic acne that you think of, even I saw a 10-year-old recently developing
Mm,
stones, blackheads, some scattered whiteheads as they started their menstrual period. This was young girl had started her menstrual period already at 10. So we'll definitely see that
yeah.
before their period. Some people even flare when they're ovulating, and that's how the birth control pill can kind of help even some of that out. But we see acne when people are on birth control pills and off them. It
It
depends.
doesn't matter.
It doesn't seem to always matter. Yes.
Gotcha. Gotcha. So, do you think the people who develop acne have more of like predominance of the androgen issue versus insulin insensitivity? I mean, those can be connected in a way, but have you seen any sort of like the androgen predominant type being more acne related versus not, or
Well, I think that's when you look at the other factors. You look to see
yeah,
if they have excess hair growth or if they have signs of hair loss. And that would kind of lean toward a more androgenic. But, acne is a combination of things. It's a combination of a lot of heredity, whether their
okay,
family or auntie had bad acne during their teen years or, and
yeah,
I think then there's triggers, the stress. We call it heat, humidity, hormones, and stress. And in Washington,
okay.
D.C., we have them all. And in many states, you have
So
them
he,
all.
okay, okay.
And now we probably have to add diet because that was something, again, that was not, kind of acknowledged. And we know now that there do seem to be dietary triggers in a lot of patients.
Yeah, so for, people in functional medicine with general like PCOS, they may or may not have the acne. We always recommend a low glycemic diet, and we also advise like elimination of gluten and dairy if they can help it.
Mhm.
But it's not, the diet is one source, and then exercise, of course, and stress management, because part of the, conversion that's happening towards androgen is related to cortisol, believe it or not. Cortisol is always like playing a role there. And so stress used to be just like a social phenomena, but the more we are looking at it, it looks like it's more of like a medical issue, if you will. And so thank you for that. So about the dark patches that women have, um, that's another concern that I get is like dark patches, especially around the neck and underarms. So how do you like what is your perspective about this? I know it's from insulin resistance. So
Mhm.
what do you normally recommend for that?
Honestly, it's been super challenging to deal with
Okay.
this nigricans over the years. They call it the
Okay.
pigmentation here, the pigmentation under the arms. But I think now, with more knowledge about the diet and the GLP-1s, we're realizing we probably need to think about using them in patients at a younger age. I know I recently saw an article showing the GLP-1s may be helpful for infertility. So I wonder,
Oh, okay.
it seems to me like we might start approaching the PCOS in a different way, really getting to the cause of the insulin resistance.
Yeah.
And there have been some reports of the pigmentation improving as the insulin resistance improves. But topicals are not, they can be a little helpful, but not anywhere as helpful as helping change the whole essence of the insulin resistance. Mhm.
Gotcha. So what's some of like the topicals? Are they like
I mean, we would use,
whitening stuff, or like what are the topicals that are used in this instance?
You can use a tretinoin or a retin-A, but it can be very irritating, as you can imagine, under the arms. Definitely sunscreen so that you're not getting the pigmentation trigger. We also see a lot of people that get pigmentation on the face, just post-inflammatory hyperpigmentation from the skin being inflamed. And that can be really concerning to a lot of people to they've calmed down the pimple, but the brown spot lasts for months.
Yeah.
It's very disturbing, especially for many people of all ages.
Yeah.
Matter.
Yeah.
But again, the spironolactone can help. So that's a very important medication for us with not too many side effects. It seems to be best taken at night. And I start as low as 75 milligrams. You can go up as high as 200. I would say most of my patients are taking 75 to maybe 125, higher if they have pretty significant hirsutism or excess hair. But we'll see incredible improvement using spironolactone, and then a topical like that unplugs the pores, tretinoin or adapalene, also known as retin-A and different, were the original names of them. Yeah.
Gotcha. So I've seen some women go for laser treatment for hair removal.
Mm-hmm.
Talk to me about that. I was told that if you shave, more hair will come. And so, yeah, talk to us about that.
Well, laser hair is very effective in the right hands in a person who has the right laser and does the right settings. The problem with it is it's targeting the black hair, the hair bulb. And so if you have darker skin, what is darker skin? Even for me, I have to be treated like I am a person, we call it type 3-4, because I have a fair amount of pigment in my skin, and the laser will not be able to tell the difference between the pigment of my skin and the hair, and you can get burned. So I would say that's a really important thing. The thing about the shaving is a myth.
Okay.
So that's good. Everybody still thinks that. You're better off shaving or using electrolysis or threading than you are plucking. The plucking causes oftentimes inflammation at the hair bulb, and you'll get bumps and cysts, and you can even get scarring. So we often will use spironolactone for excess hair, and there is a topical called eflornithine.
Okay.
Eflornithine was had a label. It was available by prescription, but it's not available anymore. It has to be compounded. But it's very easy to use. It's just a daily topical. Yeah.
That people can use for like the hair in the places they don't want.
Yeah. It's not a depilatory. It's not going to remove the hair. So you have to either shave or have waxing or threading done first. And then it's keeping the hair from growing.
I see.
Yeah.
So something like that you would have to use like daily, basically.
Mm-hmm.
Gotcha.
Yeah.
So how about those who are like, I want hair here, and like PCOS causes hair loss in some places that we don't want it, and hair grows in places that we don't want it. So what about the hair growth aspect? Like, what are some of the things that women can do when it's being driven by PCOS?
So again, spironolactone is working on both. It's stopping the estrogen-driven hair in places we don't want it, and then it's slowing down that thinning, the female pattern androgenic alopecia, the female pattern loss at the same time. The other thing that we know is that vitamin D is often low in a lot of people. So vitamin D helps hair growth, and it also helps acne. So that's a very cost-effective treatment. We also know that B5, pantothenic acid, is helpful for acne. And then zinc is too. The problem with zinc is sometimes people will get a little upset stomach with zinc. So I tend to be recommending that they get their vitamin D level. For me, I like it at about 50, even though the lab will show 30. What is
Yes,
your philosophy on that?
70 is what I like.
Okay. No, good to
Because because back when I was in grad school, which this is like 2012.
know.
Yeah, very, a while back, I we did a study and we were looking at women who developed gestational diabetes, and we followed them and did vitamin D supplementation. And
Mhm.
so we looked at their risk of developing type 2 diabetes, because with gestational diabetes you have high risk of type 2 diabetes, and vitamin D supplementation actually reduced that risk. And so since back then we were still learning in medical school that vitamin D is more of like the bone hormone and bone metabolism, but there
Mhm.
is like so much more to vitamin D. It's a prohormone. It's an inflammatory, anti-inflammatory. Besides modulating bone health, there's heart health, type 2 diabetes, and now PCOS. And so I like 70, and I usually tell people, in the winter time to. I see people on vitamin D and it's like 1,000 IUs. I'm like, that's not going to do anything,
Exactly.
especially when you are in the Northeast. In the winter, it's not going to do anything. And so 5,000 at least, and 2,000 in the summer if you are outdoor. But I'm talking to a dermatologist, so I know you are proponent of sunscreen, and without the sun penetrating the skin, you can't make any vitamin D. So what do you make lax like room for vitamin D production with your practice? I know it's a little detour, but
No, but I agree with you. I think most people need 5,000. I mean, our concept has been that what I've understood is I don't think we're absorbing vitamin D as easily as maybe we used to, or we were all walking around with low vitamin D and nobody was checking it. So
correct,
I like people to take the vitamin D, still wear the sunscreen. You're still going to make vitamin D because, sunscreens are not perfect and we're still getting,
correct.
but you can't lay out all day and make the right amount of vitamin D. It has to be, the D3 has to be in your system. I'm more of a proponent of the over the counter vitamin D, aren't you? D3 than the
So
prescription.
So I like the D3, but I like to take it with K2, because
Okay.
when you take vitamin D, it pulls out calcium. And when there's a lot of calcium in the blood, it ends up depositing in your blood vessel.
Oh.
K2 helps that process, it prevents that process from happening. So it's
Mhm.
good to always take the vitamin D3 with K2 in it, so for that blood vessel protection. So that's like one thing. It's like that combo makes all the difference
Well, thank you
with
for
vitamin.
explaining that because you see it everywhere and it can be overwhelming for patients. Why is this one see D3 and this one says D3K2? So now that makes sense. And it,
Yeah.
we see it in men and women that their vitamin D level is very low. And it could be low as 10. Haven't you seen it extremely low?
Oh
And
yes, I've seen it very low, especially in dark-skinned individuals like myself,
yeah.
where getting any sunlight to penetrate to make the vitamin D is very, very challenging. You would have to be in the sun for 3 hours
Mhm.
plus to just make a few IUs of it, only for it to be depleted. So absolutely, yeah, it's so key. And a lot of doctors or conventional doctors don't check vitamin D level because the message is like, just assume it's low. But depending on how low it is, it really advises how aggressive I am with supplementation. Sometimes I have to do the 50,000 IUs to quickly bring the levels up, and then do a maintenance dose of like the 5,000 and 2,000, if you will.
Yeah.
Yeah.
Yeah, I think you're right. it's very difficult to get it up in some people, and we often see
Yeah,
women of color, people in a color that they can't absorb it. Yeah, it's really
correct.
it's the gift and the curse. You're not burning, but we're not absorbing vitamin D. So it's
Exactly.
yeah.
Exactly. And also because it's a fat soluble vitamin, it's good to take it with food. So it helps with the absorption. Um, as far as the fats in your food, assuming you are having some healthy fats, of
Yeah.
course, like, and not just a big frappuccino, like you pointed out.
Yeah.
Yeah, so
Occasionally, but I know we try not to be that strict with patients, that so you just can't have milk for lunch, breakfast, lunch, and dinner, and ice cream and pizza, and expect to not have a trigger to your acne and probably to your PCOS also. Yeah.
correct. Correct. I think, yeah, that's so we just, getting to wrap up a bit. So what, are some of, like, if you had three things to say in like practical tips for PCOS or even management of acne, what are three things you would say, and include some over-the-counter products for some of us who are cheap and don't want to spend top dollar on skincare products. Give us some hacks here.
Well, I definitely believe in that. There's so many great over the counter products. We're big fans of CeraVe. Sometimes you just fall
Okay.
in love with one product line, not because it's the only one, but you get to know it. So it's a gentle cleanser. It often has a moisturizer that you can use that's not comedogenic. It's not going to make the acne worse. And then we always
Okay.
make our patients wear sunscreen. You also can get over the counter. You can get adapalene, also known as
Okay.
heparin, which unplugs the pores. So if someone can't get to the dermatologist, or maybe they're not able to go because of their insurance at first, that's a good first step.
What
We
is the name again, Dr. Dintiman?
It's called the generic is adapalene, um,
Uh-huh.
and then differin gel is available, and so that's the part that
Different. Yeah.
plugs the pores. And then benzoyl peroxide is available. There was some controversy with that for a while. They were finding benzene in the products. So we had switched over to using some other products called CLN wash, which is kind of an antibacterial wash. That's great for athletes and especially on hair bearing areas. So if you have an athlete with, breaking out on their back, their chest, their leg,
Yeah.
that's a great over the counter. And then to try to get to your dermatologist, if you can't go in person, you can have a virtual visit. We have an app that's you can use in some states, and I know there are others available because to care is still a big issue in dermatology and,
Pathology. Yes.
and in many specialties. So I think getting off to a basic start and then looking at your diet. What are your triggers? Again, we talked about dairy, you know,
Yeah.
bread, white rice, noodles. They seem to be not the friend of the person who has insulin sensitivity, which a lot of us do. Do you agree?
Yeah.
Mhm.
Yes, yes. And I think one hack around rice that I have been trying, because my diet is very rice heavy, is after you cook it, putting it in the fridge and sort of dampening down the starchiness of it, and then rewarming it before eating helps a lot. It helps reduce the glycemic load of the rice. So that's a hack that I've been using so I can keep eating rice because I love rice.
I love rice. I love rice. I could live on rice. I
Yeah.
just learned that, and I was so amazed. So it really is true. You can.
Yeah, it makes a difference. So I wore what I did because I doubted it. I was like, that's silly. Like, so I was wearing a glucose monitoring device, and I tried, eating the rice, right after cooking it versus putting it in the fridge and eating it and rewarming it. And I paired it with the same protein. So there wasn't like, because, usually when you pair high carb with good protein, it helps to balance the insulin spikes and the glucose spikes. And so I paired it with the same protein. And sure enough, there was a difference. There was about a 30 nanogram per deciliter difference with my glucose. And so I said, okay, this is what I'm doing.
That's awesome. Now,
Just like, yeah,
do you start
go
most
ahead.
patients on a birth control pill when you're treating their PCOS, or what are your criteria for that?
So a lot of people who come to me don't want birth control. That's why they come to me. A
Okay.
lot of them don't want birth control. So we treat it from the perspective of the insulin resistance. We also do a lot of work on the gut. So that's like the foundation, because we have different um, gut bacteria that is better at metabolizing glucose, like the Akkermansia. So I don't know if you've heard of the Akkermansia probiotic. So that bacteria we know is very good with breakdown of glucose. It also helps to increase GLP-1 levels. It helps to
Mhm.
curb appetite. And so one product line that I use is
Oh,
pendulum. So they have like a professional glucose line that's basically a probiotic that
mhm.
I would put, I would start people on. Also looking at the diet, how to how to balance the hormones naturally, and a lot of like stress work to reduce cortisol. So I typically will check saliva hormones like cortisol, the different times of the day to see where people are. Because when it comes to cortisol, we have people who are, you know, wired but tired, meaning that their cortisol is so high, and but so they are wired, but they are so tired also. And then we
Mhm.
have people who are flatlined, meaning that their cortisol response is not as brisk or is not as robust. And so, depending on where someone is on the spectrum, we work with them to balance the cortisol. We work with them to naturally balance the hormones. Because when someone comes to me, they are not interested in birth control. They are just not. Um, and, birth control has its own side effects with bone health and the persistent inhibition of the surge. It has its own effect. It's not, I don't know if it's meant to be something someone stays on for life. Like, I really don't think so, and I think that there is like a wave of younger women who are absolutely no to birth control. I don't know if you've come across them in your practice, but
Yes, and I agree with you. I've not been one to use that, but I defer, of course, to you or the endocrinologist on that aspect, except using the spironolactone. But I don't emphasize that they need to be on that form, an oral contraceptive, I guess I should call it, because if they choose to be,
correct.
IUD, other forms, I think it's fine. I do see more acne in patients that get the Depo-Provera shot, and sometimes in
Uh-huh.
the implant. But yes, we've seen young women that'll even say they have vaginal dryness on birth control and sometimes on spironolactone. Ironically, I ask everybody, I think I've only
Mm,
one out of maybe 1,000 that have said they've had some vaginal dryness, but it is a possibility. So yeah, I think it's great that you're getting to the concept of helping them think more holistically with their stress, their diet, and other things that can be changed in their environment. And I'm so interested in the gut bacteria and how that's going to play out with this too.
yeah, so that line that I was talking to you about, they have that product that is basically a probiotic, and they did research and studies on it, and it reduces the A1C by zero point 0.6 after 3 months of use.
Mhm.
without changing your diet, without making any changes in your lifestyle.
Mhm.
So that was like a an eye opener. So that's one thing. And then, depending on the situation, I will, if all these measures fail or if people are not consistent for whatever reason, then we may do a metformin.
Mhm.
But what is important with metformin is to supplement with a CoQ10 and a B vitamin, because metformin depletes the B vitamin, especially B12.
Mhm.
And so you want to supplement and replenish that, and so that it makes it, you know, a-okay with metformin. But a lot of people who come to me are just simply not interested in medication. So we have to get to the root and treat it. And I always tell them this is the longer way to your healing. But once you get there, at least you know that I don't have to keep taking something every day. But this is like my new lifestyle.
That's great. Do you think that testing for different food sensitivities is helpful? Any type of like genetic or seeing if oxalates or cruciferous vegetables are inflammatory or bothersome to a patient? Do you?
Yeah, yeah, I think that it's a good basis for a lot of people, because recently I had a patient who was experiencing a lot of bloating, a lot of gut issue, and so we sent for this test, and she came back. It was so weird. She's sensitive to celery,
Oh
which
wow,
is, yeah, it's,
yeah,
and so she took it out of her diet and she feels great. She says she feels better,
yeah.
and uh, I said, okay, well, you would never think of that, because you eat celery in very small amounts. It's not like you make celery pasta or anything. So it's not like you're eating it in like a large amount to clue you that maybe this is not good for me. So when it's difficult, I guess, to get to gut issues, food sensitivities is something that I test, and it also reveals whether you have gut permeability, and so, or intestinal permeability, which sort of lays the room for autoimmune diseases and thyroid issues, which can exacerbate things like PCOS. So we
Mhm.
like to do the food testing for that reason. We just, because autoimmune sets you up for thyroid issue, and the thyroid is the powerhouse of a lot of these metabolic issues. So,
Interesting. Do you,
yeah.
out of curiosity, I find that the label PCOS can be really disturbing to a lot of my young patients, and I
Yeah.
do not try to use it, unless they've already come in and told me that. I might talk about the individual symptoms. Um, do you find that it's an incredible trigger that people think, oh, that means I'm going to be infertile? And it seemed to have that connection, and it's very disturbing, I think, when it's used casually without explaining to a patient that this is
What it
treatable,
is.
manageable.
Correct. And that is very true. And I think the most important thing is for women to realize that PCOS does not mean you are infertile. It's not, there are women with PCOS who have conceived, because not all the cycles become ovulatory. There are times when you will ovulate, and so people get pregnant. So I think that exploring what PCOS means to the patient is a way to start, like, so that you can see what they are afraid of, what are their fears around it, and answering their targeted fear, because for some people it's not the infertility. For some people it's the look, like, aesthetically they are more concerned about it than, or for some is the hair. So it's just trying to explore with, like, individual patient, what does that mean? What does this mean to you? Or, what are you worried about? And I think that helps so that you can treat the things that they are most worried about first, because the stress will make everything else worse if you don't get to the fear, what fear they have around it. Yeah, it's a term, I think it's going to go away soon.
Mhm.
Just like we've gotten rid of non alcoholic fatty liver disease, they've
Yeah,
changed the term to call it what it is, which is it's like a metabolic issue.
metabolic.
And so is PCOS. So I know that in time, that name is going to go away, especially since you don't need to have cysts to be diagnosed with it. So why is that term still there? I think it will change. Yeah.
Yeah, and I think in keeping what you said, the skin is always a window to what is going on internally. And so by coming to the dermatologist or your functional medicine doctor with the concerns of the skin, the hair, it gives us an opportunity to calm not only that down, but to also help you internally. So it's going to be a
Exactly.
win-win in the end, right? Yeah.
Absolutely, absolutely. And isn't the skin the largest organ? Am I
Yes, it
right?
does.
It
Yeah.
is.
I
It's
always believe it's a sign of what's going on internally. We know that. We know from different
absolutely.
rashes, from different signs. We have to ask a little deeper to find out what's going on to really help a patient. And
Yeah.
everything you've said, it's so amazing. I think we're
Yeah, and
great things ahead. Great things ahead with knowledge.
yeah, that name will change soon. I really believe it because it's a metabolic issue and it should, really indicate that. So, yeah, well, I thank you so much for coming on. I know you are busy with your clinic. How can my patients and audience find you? Yeah, tell us how we can find you.
Yeah, so we're definitely on Instagram. We enjoy that, and a little bit on Facebook. So we're always having a lot of fun trying to teach people about, like you said, products that are easy to get, different myths and facts about dermatology. And then we're in Vienna, Virginia. We're also available on the Derm Utopia app. This one is
Dermatopia.
available in Virginia and Maryland and not other states. So it's a little bit difficult to have licenses in all the states. But if you're in either of those states, it's something you can do online and get a consultation. So hopefully, this has been helpful for everybody. Yeah.
Yeah, this has been wonderful. Thank you so much for your time. Ladies, please check Dr. Brenda Dintiman out on Dermutopia, on Instagram, Facebook. She is an amazing human being. I know her from here, just being here. I know that if you reach out to her on those pages, you will get a wealth of knowledge about your skin, not just PCOS, because she covers the gamut of it, especially for my perimenopause and menopause women. There's so much out there, and I wish we had time to touch, but I'm sure we can have you come back and we can talk about skin changes in menopause. So yeah, if you are out there and struggling with PCOS, you are not alone. It's the most common endocrine dysfunction in women. So seek help, get help with, licensed professionals. I will say it again, with physicians and licensed professionals, so we can get to the root cause and get complete recovery. Thank you so much for joining us. Thank you so much, Dr. Dintman. I appreciate your time.
My pleasure. Thank you.
All right.